Thank you so much for joining us. Hello, everyone. My name is Gwaunza, and allow me to introduce our guest speaker today, Dr. Gwaunza, who is a renowned neurologist, and he specializes in stroke medicine and intervention. Dr. Gwaunza is a former lecturer at the University of Zimbabwe, and he will be talking to us today about stroke and mental health. Thank you so much, Dr. Gwaunza, for joining us today. I will hand over the floor to you.
Thank you, Wadzanai. So I'm just going to have a small chat on stroke and mental health disorders. I titled it A Growing Silent Epidemic in Zimbabwe and Africa. I hope by the time I finish the presentation, you realize why I called it that. So I'll start by defining what a stroke is. So by definition, by the WHO, a stroke is a rapidly developing clinical signs of focal disturbance of cerebral function lasting at least 24 hours or leading to death with no apparent cause other than that of vascular origin. So when we talk of a stroke, it could either be a stroke in the brain, in the spinal cord, or the retinal cells that could cause blindness, based on what you see pathologically, on imaging, or other objective evidence of cerebral, spinal, or retinal focal ischemic injury in a defined vascular distribution, or rather clinical evidence of cerebral, spinal cord, or retinal focal ischemic injury based on symptoms persisting more than 24 hours or until death or other etiologies are excluded. So by definition, an ischemic stroke is an episode of neurological dysfunction caused by focal, cerebral, brain, or retinal infarction. And when you're looking at a hemorrhagic stroke, this is when you have clinical signs of dysfunction, neurological dysfunction, which is attributable to a focal collection of blood within the brain parenchyma or ventricular system that is not caused by trauma. So I'll also mention what a transient ischemic attack is. According to the World Health Organization, this criteria was proposed in 1988. A transient ischemic attack, or a TIA, is defined as rapidly developed clinical signs of focal global disturbance of cerebral function lasting less than 24 hours with no apparent non-vascular cause. So there's been an increased need for us to change the definition to include a tissue basis as opposed to using an arbitrary time limit. But this proves to be difficult. So when we talk of the brain, we say time is brain. So if someone is a stroke, the earlier they present to hospital, the better, because we can actually intervene if they present much earlier. But with changes in technology, we are able, even if someone comes in after 18 hours, 16 hours, we are able to actually see if the brain is still alive and intervene during that time limit. So this is what we call the tissue-based definition as opposed to an arbitrary time limit. So a transient ischemic attack is an episode of a neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction. So when you're using time limits, a TIA is usually less than 1 to 2 hours. So if you wait for 24 hours, as some of you might know, within the first few hours, you can actually intervene either by thrombolizing the patient, that is bursting the clot, or by removing the clot, which is called thrombectomy. So the earlier someone presents, the better. So if you wait for 24 hours for you to define a stroke, that means you missed the boat in terms of intervention in stroke. So we actually like using transient ischemic attack definition of less than 1 to 2 hours because that allows us to act when the patient presents early. So I've just talked about stroke epidemiology, which is the main focus of this presentation. According to the Global Burden of Disease Study, which was of 2018, stroke is the leading cause of morbidity and mortality worldwide, is a leading cause. And it's ranked as the 7th leading cause of disability-adjusted life years lost in 2002, and is projected to become the 6th by 2030. And stroke is the 2nd leading cause of death worldwide. What's interesting is stroke incidence has increased in the past 4 decades by over 100% in low and medium income countries, while it has declined in high income countries. Unsurprisingly, stroke incidence is increasing in sub-Saharan Africa. And what's actually more shocking is that most deaths from stroke, that's 87% of all deaths, are actually in lower and middle income countries. And the impact of stroke as measured by disability-adjusted life years lost and mortality rates is greater than threefold higher in lower income countries compared to high and middle income countries. And the number of stroke deaths is projected to increase by more than 30% in the next 20 years, with the majority occurring in low income countries. So this is what has been happening to incidence rates of stroke since 1990. This is up to 2010. As you can see, the red line represents high income countries and the blue line is low and middle income countries. You can clearly see that there's been an increase in the incidence rates of stroke in low and middle income countries as opposed to high income countries. So the epidemiology of stroke in Africa is difficult to ascertain due to heterogeneity in the methodology. So there are several population or community-based studies reporting crude prevalence rates of stroke survivors ranging from 15 in 100,000 in Ethiopia to 963 in 100,000 and 1,460 in the Niger Delta region in Nigeria. The incidence of stroke in South Africa is largely unknown, but it is the third most common cause of death after HIV, AIDS, and ischemic heart attack. This is just next door. In Zimbabwe, it's largely unknown. And demographic and epidemiological shifts have resulted in stroke being a major health problem in lower middle income countries. So I'm going to talk a little bit about epidemiological shifts later on. So this is just to show the incidence of stroke. So the ones in red, that's where it's most common. So that would be the areas around Asia and the Middle East. And then as you can see in Africa, it's actually more common than you would see it in the US. But the problem is in Africa, as I've already mentioned, some of the data is not clear. So some of it is not documented very well. So it's very difficult to really ascertain how common stroke is. And then this is young people. So for me, what's shocking is we don't have data for stroke in young patients on the continent to a large extent. And in places where they have data for stroke in young patients in Africa, it tends to be more common than in every other area in the world. So this is a cause of concern because young patients are the ones who are supposed to be economically productive. So that would affect people who are still in their most economically productive years. And the other thing I want to mention about young patients, you have to remember the definition of a young person depends with how much money you would have in that country. For example, in stroke, when you're saying a young patient in a resource-limited country, you would probably put it at 45. Because once you shift it to 65, like in high-income countries, what would happen is you would need to wake up every stroke in every patient. That means you need to investigate. And the investigation for stroke can be very expensive. So the younger a patient is, the more you have to look for a cause for stroke. So if you use an arbitrary limit for young patients of 65 years, that means you're going to be doing a lot of investigations in our stroke patients in the country. In a study that we did here, most of the patients were admitted at Pari Central Hospital were actually less than the age of 65. There were actually a few who were older than 65 with an average age of 63, which is quite young in the world of stroke. So just to sort of summarize, there are over 13.7 million new strokes of all types each year. And globally, every fourth person aged over 25 will suffer a stroke in their lifetime. So if you're sitting with 4 people, just know one of you is going to get a stroke in their lifetime if you're older than 25. And stroke is the second leading cause of death worldwide. And 5.5 million people die of stroke annually. And stroke is the leading cause of serious long-term disability. And every year, over 116 million years of healthy life is lost due to stroke. So we just talk about ischemic stroke, which is the most common form of stroke. This accounts for 88% of all strokes. In 2016, over 9.5 million new cases of stroke occurred worldwide. And strokes can happen at any age, and nearly 60% of new ischemic stroke happen in younger people younger than 70. And even 77% occur in people younger than 45. And strokes are more common in males than in females. And annually, 2.7 million people die from ischemic stroke worldwide. And this is what we were just mentioning about sex differences, that strokes are more common in males than in females. So I'll go on to talk about the effect or the impact of socioeconomic status on stroke outcome. So what's important, just when you are looking at the literature, what you see is that it's difficult to define socioeconomic status. It is probably best described as a composite of income, level of education, employment, and social status. So studies on the effect of socioeconomic status on stroke outcomes may be difficult to evaluate due to differences in the definition of socioeconomic status. So in the US, in some studies, they use your ability to, if you have insurance, they would say you are high income. If you don't, you are lower income. And then some would use occupation as a measure of your socioeconomic status. So if you are in Zimbabwe, for example, a politician will be of high income, will be of high socioeconomic status compared to probably doctors working in the government sector. So what we know overall is that low socioeconomic status is associated with increased risk of stroke, increased in-hospital mortality, longer-term mortality, poor functional income, and interestingly, more stroke risk factors. And there is no evidence at the moment that low socioeconomic status is associated with increased stroke recurrence. And when you go into the high income countries and the low income countries, what you realize is the poorer people within a population in poorer countries globally are most affected in terms of incidence and poor outcomes of stroke. So stroke is not just causing havoc in low-income countries, it also causes poor outcome in these low-income countries. So this is just to show disability-associated life years lost compared to a socio-demographic index. So a socio-demographic index inputs the things we've talked about already, your income, your level of education, and then comes up with an index. So if your socio-demographic index is 1, that's like the perfect one. That means it's the highest, and then 0 will be the lowest. So as you can see from this graph, if your socio-demographic index is low, you tend to lose more you tend to have more disability-associated life years lost compared to someone with a much higher socio-demographic index. So that means in low-income countries, we have a lot to do in terms of taking care of the population of patients with stroke. So what about socioeconomic status and the processes of care for stroke? So a process of care for stroke, it depends how you want to look at it. So if you're looking at a process of care for stroke, the best way to look at it would be to say when you get the stroke, you call an ambulance, and after you call an ambulance, it takes you to the hospital. And what happens when you get to the hospital until you're discharged? So that would be the full spectrum in terms of your process of care for stroke. So this is a study that was done in Denmark. So what they did was they looked at individuals of a low economic status versus those of a high economic status. And they looked at 7 specific processes of care. So the ones they looked at were specialized stroke unit care, ability to get a scan, that is imaging of the brain, whether it's a CT scan or an MRI scan, whether these patients get antiplatelet therapy like aspirin or anticoagulation like warfarin to prevent further strokes, assessment by a physiotherapist, occupational therapist, or nutritionist. So what they actually found out is individuals of a low socioeconomic status are less likely to access the 7 specific processes of care compared to those of high socioeconomic status. And what's even more depressing is in Zimbabwe, until recently, we only had 1 stroke unit in the country. That was at Parenyato Hospital. However, we've managed to open 2 more stroke units the previous month at Gweru Provincial Hospital and Pilo Central Hospital. And there are no stroke units in the private sector in Zimbabwe. So the question that people ask is, in terms of stroke outcome, where would one rather be? So as I will show you later, it's horrifying what happens on a ward which is not a stroke unit in terms of stroke outcome. So then obviously when you set up your stroke unit, what you want, the next step will probably be, do people know about stroke? So we actually don't have one of those knowledge studies in Zimbabwe, but I just took a study in Northern Tanzania as an example. So in Northern Tanzania, they did a survey in 670 people, and 27.4% of the respondents knew at least 1 conventional stroke symptom. And only 5% knew at least 2. That means they knew 2 or more symptoms, and less than 1% knew 3 symptoms of stroke. That means if that person has a stroke, they have an inability to present early to hospital because they don't know they've had a stroke. So if you have close to 75% of your population not knowing conventional stroke symptoms, it means they are less likely to present to hospital. But when the 670 people were asked, if you had stroke-like symptoms, would you present to hospital? 88% stated that they would present to a hospital. So this is a nice study that looked at risk factors for stroke in Africa. And 11 emerged as the most important contributors to stroke occurrence in what's called a siren study. So hypertension had the highest contribution in terms of risk factors for stroke, with other factors in decreasing order, including dyslipidemia. So there's a misconception that Black Africans don't have dyslipidemia. It's actually quite common in Africans, as you can see from this study. Regular meat consumption, elevated waist to hip ratio, diabetes mellitus, a low green leafy vegetable consumption, stress, adding salt at the table, cardiac disease, physical inability, and tobacco use. So what is clear is innovative prevention strategies targeting people in low socioeconomic groups are required along with effective measures to promote access to effective stroke interventions worldwide. What about mental health? So people may ask, why does a neurologist have an interest in mental health? So in 2018, we saw 6 children living on the streets who were admitted to a central hospital in Zimbabwe with difficulty walking. They all had a sensory motor polyneuropathy, and this was due to glue sniffing, an annexane neuropathy, that's what that's called. Then we have functional neurological disorders like functional weakness, functional seizures, fibromyalgia. there may be a link with mental health disorders, and the condition itself, having fibromyalgia, having functional weakness or seizures, impacts on people's mental health. And various neurological disorders which impair functions and at times occur dramatically, like a stroke, or have no cure, like amyotrophic lateral sclerosis or motor neuron disease, have an impact on individuals' mental health. So what do we know about mental health and addictive disorders? We know that they affected more than 1 billion people globally in 2016. And they cost 7% of all global burden of diseases measured in DALYs, and 19% of all years lived in disability. Depression is the most common mental health disorder, and there's a high burden, particularly in high and middle income countries. Although there are less cases in low middle income countries, we should always keep in mind that this data is based on population surveys in areas where there's stigma. Treatment and preventive intervention for mental and addictive disorders are still lacking in low and middle income countries. So this is just to show disability associated life years lost, DALYs, due to addictive and mental disorders. As you can see, South Africa and Botswana have a high number from the coding there. Zimbabwe isn't too far behind. And we have to remember as well that some of these is the same with mental health. The problem with mental health disorders is there's a lot of stigma. So people are less likely to present to a hospital or to admit to having a mental health disorder. What actually happens is some are actually sent to the rural homes to stay there. And I actually had an amusing taxi ride when I was talking to the driver, and he said to me, do you know that people are stealing plasma TVs so that they can smoke crystal meth? Obviously, I thought he was joking. So I started asking around, and it seems people are actually doing that. And in the high density areas, there's something called bulb, where they take energy saver lights and they use that to smoke crystal meth. So this is what is happening in our country, but we don't know the extent because of the stigma around, associated with mental health disorders. So these are just some of the mental health disorders. Depression, as you can see, is the highest number. Anxiety disorders as well. Anxiety and depression. Then bipolar, attention deficit. Then any substance use disorder, as you can see, that's quite high. So these are things that we have to look at and remember. These conditions may actually be more common than we think in our country, but we just don't have the data. So is there a strategy to tackle non-communicable diseases? So the WHO's initial aim was to reduce premature mortality, that is death in less than 70-year-olds, from 4 non-communicable diseases. And these were cancer, cardiovascular disease, chronic respiratory disease, and diabetes by a quarter of 2010 levels by 2025. Obviously, the concern was that mental and addictive disease had become forgotten because no one talked about them, because it doesn't seem like they cause a lot of direct deaths, but you have to realize close to 1 million people commit suicide every year. But this won't be as huge as some of the figures that are posted by some of the medical conditions. However, it contributes a lot to disability. So there's now been a shift in the UN Sustainable Development Goals. And they've changed the target for premature deaths. Instead of a quarter, they've made it a third by 2030, which may actually be very ambitious, and promoting mental health and well-being by 2030. So in Africa, you can understand the focus on the high infant and maternal mortality because of the high infant and maternal mortality. So you need to address that. But you can't certainly ignore non-communicable diseases because you may save the infant, but not have anyone to take care of them. So it's a very important way to look at non-communicable diseases. So what about Zimbabwe? So what we know is non-communicable diseases cause approximately a third of all deaths, so they cannot be ignored. And there's growing burden of non-communicable diseases in patients living with HIV/AIDS. So as you get more people living with HIV/AIDS on retroviral therapy and they live longer, they will get more non-communicable diseases. So I'll then talk of this concept of epidemiologic transition. So this was defined by Omran in 1971. And it is essentially when mortality and disease patterns evolve from a high and fluctuating mortality in younger people, largely secondary to infection and nutritional deficiency, which were called diseases of poverty, to much more stable mortality in older people, largely due to non-communicable diseases and injuries. So is this already occurring in Africa? That is the question. So most likely this is already happening. So in a study in 2017, published in 2017, Kadubura and colleagues reported that there was epidemiologic transition in rural South Africa. So I did a small study. So in the 1980s and 90s, there were reports that extracranial carotid stenosis was virtually non-existent in Black Africans. But in a small retrospective study that I did at Tygerberg Hospital in stroke patients, we noted extracranial stenosis in 5% of Black Africans. So this is from 0 to 5% in less than 30 years. So epidemiologic transition is already happening, and we already have high burden already. So that means our burden is going to continue going up. So what is being done in terms of stroke medicine? So as I've already mentioned, there are now 3 stroke units in the country. We have Parenyatwa Group of Hospitals, Gweru Provincial Hospitals, and Mpilo Central Hospital. So in terms of structure, the stroke care in Zimbabwe is probably better in the public sector than the private sector. That is structure-wise. I'm not talking about resources, but structure-wise. Although we are resource limited in the public sector, we have managed to reduce 7-day in-hospital case fatality rates from 24.7%, that is in an ordinary ward, to 7.8% using a stroke unit. And in this stroke unit, we are using low-cost interventions. However, the one problem we still have is the disability post-stroke. One of the reasons is we don't have rehabilitation facilities to send our patients post-discharge. And to those who would want to go there or want to refer, they can't afford St. Giles, for example. So it's a very difficult situation where you save someone's life, but their quality of life is not as good. However, what I would say is the hospital administration at Parenyatwa Group of Hospitals and the Ministry of Health, the Permanent Secretary, has been very supportive in upgrading our stroke care. So what I just want to highlight is the problem we have in the public sector. So one of the advantages of having a stroke unit or a stroke team is you are able to improve outcomes of patients, whether they're actually admitted into the unit or not. And you are also able to react faster to a stroke than if you don't have organized stroke care. And the outcome of stroke patients is actually better if it's done by people with interest in stroke, who's doing stroke. So imagine you go to a hospital and you have a stroke, and the nurse who's taking care of you is also taking care of someone with diarrhea. Obviously, the way they will take care of you is different from a stroke nurse who's only taking care of stroke patients. So I'm just going to describe this case of a 64-year-old who had been admitted to Pari Hospital for chronic kidney disease, who was noted to have facial droop while eating. The stroke team was called in to assess the patient 14 minutes after the onset of the stroke. And our assessment was that this was a lacuna stroke. And we used a severity score, the NIH stroke scale of, so the NIH stroke scale of this patient was 7. We requested for a CT scan. This was 30 minutes after the onset. So we managed to quickly assess this patient, and within 15 minutes, we had finished our assessment and we requested a CT scan. However, we only got the CT scan after 5 hours after the onset. The reason is the CT scanner, main CT scanner at Parenyatwa group of hospitals is not working. So we have to rely on the CT scanner for oncology department. And that can be overbooked. So that meant our patient only got a CT scan at 5 hours after the onset. Usually our cutoff is 4.5 hours if you're just using a plain CT. So we tried to get the relatives to buy Alteplase. So Alteplase is not available in Harare, but Tenecteplase is. And Tenecteplase cost $1,060. So the family just called and said, we can't afford it. So we learned a few lessons from this. The structure is there. However, we don't have the tools. And once those tools are there, thrombolysis is actually possible in the public sector. So at the moment, this is still a dream, but we definitely can make a difference just with the stroke units. This is in stroke care. For mental health disorders, I actually think for me to present, I would actually not do the topic justice by presenting it, because it seems like it's a more broader topic. So in summary, I hope with this presentation, the following have been clearly highlighted. Stroke, mental health, and addictive disorders are a problem in Zimbabwe that need attention now. There is an urgent need for epidemiological research to clearly study the burden of these illnesses in the country, because that also helps with budgets. And there is a need to come up with cost-effective treatments and preventative strategies for these conditions in our country. And one thing I probably did not mention in the presentation is we need to lobby for support of people who have disability. And this may even include government only giving tenders to companies employing a certain percentage of people with disability. I think this is the end of my presentation. I don't know if there are any questions.
Thank you so much, Dr. Gwaunza, for such an insightful presentation. And I understand there are a couple of questions in the chat box, with the first one being, given that poverty or low socioeconomic status is not the same in developed countries, say USA, where these studies are conducted, where the minimum wage one gets is about 30,000 per year, versus countries like Zimbabwe, where one gets less than $1 per day. So how translatable are these studies to stroke outcomes in poorer countries? And how can we best interpret these studies in a manner that is applicable to poorer countries? Okay,
so the studies that I quoted were actually global studies. So they were multinational studies, including low-income countries and high-income countries. That's for the global burden of disease. And then for socioeconomic status, it's a bit difficult to judge socioeconomic status in Zimbabwe. I'll give a good example. You are seeing someone in the private sector, and you look at them and you think they can't afford. You ask them their occupation, they are not employed. So you think they can't afford. And when you go outside, they are driving an S600. So it's a bit difficult to judge the socioeconomic status in certain low-income countries. But what we know is, even in those countries we're able to, that is in low-income countries, we know that these results are similar, whether in a high-income country or a low-income country. If you're of a low socioeconomic status, your outcomes tend to mirror each other. So the research is translatable, and I think I've also highlighted some of the studies that have been done in low-income countries that show the same thing, that low socioeconomic status is associated with poor outcomes in stroke. I don't know if that question has been answered.
Thank you so much. The second one would be, what do you mean by disability adjusted lived years? Is there a connection to our economy and healthcare overall?
So disability adjusted life years is, you are then looking at, let me see if I can get the more accurate definition, because it's easier when I have an accurate definition. Right, so when you're looking at disability adjusted life year, it's the measure of overall disease burden expressed in the numbers of years lost due to ill health, disability, or early death. So it's used as a way of comparing the overall health and life expectancy of different countries. So what you're saying is, if this person had not gotten this condition, they were probably going to live until they were 75. But they got this condition when they were 40. So they have lost 35 years due to disability. So there is a connection to our economy and healthcare overall, because if your healthcare delivery system is poor, or you're a low socioeconomic class, or you are from a low income country, you are more likely to suffer more, to have more DALYs than someone who lives in a better country than you do. I think that's the way to look at it.
All right, thank you. What can individuals, communities, and institutions do to reduce the burden, prevalence, or even the incidence of stroke?
So for us to be able to do that, that's a brilliant question, which is actually a difficult question to answer. So for us to be able to reduce the burden, prevalence, or even incidence of stroke, we need to educate the population about stroke. And when we have educated our population about stroke, we also need to do studies in terms of risk factors for stroke. If you don't know the risk factors for stroke in your population, you don't know what to control. Fortunately, we know hypertension is the biggest risk factor for stroke. So if we identify people with hypertension and treat them early, we will reduce the prevalence of stroke. Then there are dietary patterns, obesity, so exercise. So these are all things that can be done to reduce the prevalence of stroke. But all this can be done with better education strategies. The problem or the dilemma that we face is, if I go out on national radio or national TV, and I say, when you have a stroke, these are the symptoms of a stroke, you're supposed to present to hospital early. And the reason you're presenting to hospital early is we can intervene. If they then present to hospital early and you cannot intervene, well, I'm giving an example of Tenecta Place, which is 1,060. A CT scan will cost you about $200. Getting a good ambulance. So you find the cost of getting these people to the hospital early and intervening might be $2,000, which we might not have at that particular moment in time. So already there is a compromise in care because of our low income status. So that is the trouble that we face in terms of intervening in some of these non-communicable diseases.
All right, thank you. What's government's position? Are practitioners getting any support from the government to promote this area of health?
So I'll speak on my behalf. I won't speak on everyone's behalf. So since I've been in the country, we've been helped tremendously by the hospital administration and by the ministry in terms of stroke care. The problem obviously is funding, and we need to look for a sustainable model for funding. Already, COVID overtook events for us, and there was prioritization of COVID funding because of the COVID pandemic. But when you look at COVID itself, it also increased stroke risk, because COVID patients can also get stroke. So again, there's always a link that comes back. If you look at infectious diseases, HIV, you look at syphilis, you look at TB, they can complicate with stroke. So the problem at the end is funding. So when you have a problem with funding, even when you have the best intentions for a project, they end up not being successful because of lack of funding. But what we can try to do, I see the next question will be on stroke care in rural areas, is trying to set up stroke units. So setting up a stroke unit might seem like it's very simple, but I'll actually give an example of where I trained my neurology training. I did it at Tygerberg in Cape Town. They set up a stroke unit in 2016. Zimbabwe had already set up a stroke unit in 2013. So Paris set up a stroke unit before Tygerberg, but the advice was from UCT, which is Groote Schuur Hospital, which had set up a stroke unit much earlier. So if you actually look in Africa, most countries don't have organized stroke care. If we are to have a stroke unit in rural areas, one of the proposals was to have a nurse-led stroke unit, and using telemedicine, contacting the stroke teams at the central hospital for assistance. But this is a work in progress. At least when we have central hospitals set up, we can always go to the smaller hospitals, provincial hospitals and district hospitals, and set up the same stroke units.
All right. So since there's a strong connection between stroke and mental illness, as someone who's interested in psychiatric issues and neurologist, how then would you compare being psychiatric versus physical interventions on post-stroke patients? So should intervention focus more on psych or physical intervention?
So what's actually, if you actually look at stroke, the most important people are actually not doctors. We always emphasize that on our stroke team, that I am the most useless person in that unit. So the most useful people are the rehab team, the nurses, and counselors who are on the ward, nutritionists, because some of these patients get depressed when they get a stroke. And the reason is it makes sense why they would get depression, because these are healthy people who are functioning in society, and they are struck down by a stroke while they're at work or while they are working. All of a sudden, their life is upside down. They are not formally employed, and they have to be physically active for them to be able to make a living. So both interventions at the same time are important to answer your question. You need input from psychiatry, from psychologists, from rehab people, because you need the people to be active much earlier so that you prevent contractures, you prevent complications of prolonged bed rest. So both interventions are important. The doctor comes in to manage complications and to investigate for the cause of the stroke so that you can come up with an effective preventive strategy for stroke recurrence. I don't know if that has answered your question.
All right. Dr. Gwaunza, do you know of any current studies or research being done in Zimbabwe to get accurate data on the burden of stroke/NCDs in our country?
At the moment, there is nothing. So I'm hoping from this presentation, we'll be able to get people interested in coming up with, in conducting such studies, population-based studies, to come up with accurate data on stroke and mental health and addictive issues. So to answer your question, the answer is no, but hopefully we will have people who will be doing that soon.
In what ways do you suggest grassroots organizations organize public health campaigns to spread information of stroke symptoms so that the population can seek immediate care?
Yeah, so this is where I think I discussed this in briefly. So it's a very complicated ethical question, because once I go out there and I tell people, if you present early to hospital, be able to intervene. Then they come after 1 hour, and then I look at them, and then I'm not able to send them for a scan because they can't afford it. And if they do afford the scan, they can't afford the medication. Is it ethical for me to do that? So it's a very tricky question. But what we could probably do is to ask people to present early to hospital. Make sure, if I'm to add this, make sure you don't feed a stroke patient before they get to hospital. So what's actually quite interesting is when we did our stroke study at Pari, for those who know where Pari Central Hospital is, it's very close to Avondale. So the Avondale shops, it's actually a walking distance, about 5 minutes. So even people from Avondale presented to Pari Hospital 18 hours after the onset of the stroke. So what's actually quite interesting is the stroke happens in the morning, and people believe some of the symptoms will get better. Then they go to work, and then later on call the person who's supposed to pay to foot the bills and say the stroke symptoms are not getting better, or the symptoms are not getting better. Let's take them to hospital. And then 18 hours later, they come to hospital. So there are a lot of structural issues. And then we can also include ambulances. The ambulance services are not very good. So you can call an ambulance and not get one arrive on time. So we can go and have these good grassroots messages, but if the system is not right, we may actually cause more distress. Although I'm not saying we should not do it, we might cause more distress when people are sitting in and saying, we could have done this, but we're unable to do it because we don't have a car. There's no ambulance that can get to us on time. So these are all, I think it can be a discussion where other people can contribute and come and suggest how best to tackle the question, because it's a complicated question for me.
Okay, thank you. And then, is stroke in itself hereditary, or the heredity lies in risk factors?
So rarely stroke can be hereditary. Very rarely it can be hereditary. So there are certain conditions where strokes are hereditary. So for example, I don't want to get too technical because I don't know the audience I'm talking to, but some strokes are hereditary. And the risk factors, some of them, they are multifactorial. So the genetics may play a role. So for example, in weight, genetics may play a role, but diet, inactivity also plays a major role. So it's multifactorial in that sense. So yes, there might be effect of genetics, but remember, if you live with someone who overeats, you're more likely to eat more. Your salt habits, adding salt on the table, depend with the people you live with. If there is a rule that no one adds salt on the table because JD is hypertensive, the children are less likely to add salt, and that's what they learn, and that's how they live. So sometimes the genetics might be overemphasized when most of the factors are just environmental.
All right, thank you. And I guess our last question would be, so on a more general perspective, besides the limitations in funding, improving the state of public health suffers marked gaps in research. How do you think we can best engage more people, especially youth, in bridging this gap? And what would you say is the general attitude towards research studies among Zimbabweans?
So I think this is a difficult question to answer. The attitude among academics sometimes is research might be a waste of time, but you have to look at academia from a different light. So academia works best when there is a culture of academia. So people look at academia as teaching, but it's more than just teaching. So university service, for you to get promotion, they look at research, then look at your teaching record. So if you're a member of faculty, you need to be able to pull in grant funding, right? So for you to be able to pull in grant funding, you need to come up with good ideas, which are translatable and can lead to changes in people's lives. So one of the problems we have is when we look at non-communicable diseases. I know the NIH has increased funding for non-communicable disease in Africa. You find most people are interested in infectious diseases, infant and maternal mortality. So you find the research will be focused there. What we need is to have people focused on research in non-communicable diseases. And one of the ways of doing this, for us to be able to do that, is to set up institutes of research in non-communicable diseases. You can start with one institute. We're just looking at non-communicable diseases. And this institute can actually address all the aspects, starting with epidemiology. So one of our problems, as you have seen from this presentation, is we have not counted. So we need to start counting. And we need people who will be willing to sacrifice to say, as I am counting, I probably won't get a lot of money for the counting that I'm going to do. But after you've done a few years of research, the money will start coming in, because they also need to know that they can trust you with money, the funders. So it's a very complicated issue when coming to research. So what I think is people are interested in research, but the problem is sometimes when people look at the salary or the lifestyles of academics, they then say, I don't want to be an academic. It doesn't seem like it gives you a lot of money. So people tend to then leave the research field and go elsewhere. But I actually think there's a lot of potential in the research field in Zimbabwe. There are a lot of unexplored things in Zimbabwe. You can even, let's say we say epidemiology, there's still a lot to do in terms of non-communicable diseases. What are the risk factors? What are the interventions that we can try, low-cost interventions we can try? So these are all things you can do research in. And I'm trying to remember what the other question was. The role of young people. So one of the things young people have to do is to come back. We are going to get young people go and get education outside. Sometimes very beneficial to our society. When they come back, they might get frustrated because that's not the life they expected. Imagine if every Zimbabwean in the diaspora came for 6 months and did something for 6 months. That would make a huge difference in terms of what we are trying to achieve. You don't have to live here forever, just 6 months of your life, or even having links with people on the ground would be very helpful, because that would mean you get more links with more seasoned researchers who can attract grant funding, and they also mentor young people in Zimbabwe so that they are able to conduct research and also attract funding by their own right. So that's the way I'm looking at young people. But there's obviously more young people could do. They could volunteer to educate communities. So if this was taken as a as a requirement, for example, to get into medical school, that you don't get into medical school until you have done something that shows you have an interest in health. And that interest could be you've educated societies about a certain condition, or you've worked in the society as a health educator or a health worker for maybe a month, 2 months. If that was a prerequisite to get into medical school, you would find young people would actually contribute more than they actually do. So I'm sure there are better ideas than I have, but this can all be subject of a roundtable discussion.
Thank you so much, Dr. Gwaunza. I'm very sorry. I know I had said the last question, but we received 1 or 2 more questions. Please just take these ones. One says, Dr. Gwaunza, would you be interested in supporting students abroad who may be interested in conducting these population studies but may not have data access?
So I would be, but what we have to remember is, for us to get this data, we might need to be on the ground. The base data we need is actually in the population. There is a time one of my colleagues, Dr. Ngwende, tried to get data for stroke for a year. And I think they could only get 3 strokes in the year, but in that week they had seen 7 strokes. So sometimes our data is not perfect. And what we have tried to do is to introduce an electronic system to capture our stroke data. However, due to the various strokes in 2019 and 2020, we have been unable to maintain that database. So we have to start again to enter the data again. But this will just be for hospital admissions. But what we actually need are population-based studies where we go into the community and ask which people, how many people have had strokes, how many people have died from stroke, and so forth, and look at risk factors in the community. I think that would be the best way to look at research, and I will be happy to assist anyone who's willing to go through this.
All right, thank you so much, Dr. Gwaunza. I think don't have any more questions, and I will hand this over to Praise Makoni.
Hi, everyone. Thank you for joining us for this meeting. Special thanks to Dr. Gwaunza. It was a very insightful meeting. We learned a lot. Well, speaking for myself, it was a lot of terminology that I have to go and research on the internet, but it was quite factual, and I'm sure all of us can attest to that. And I think we've seen that there's a lot that has to be done in terms of mental health, and it's not just about depression only. There are a lot of causes of mental health. And also thank you to our board. Thank you to everyone who joined us. From the Pora Health team, would like to say thank you for joining us for this special meeting. I hope you learned 1 or 2 things. Let us continue to raise awareness on mental health, and I'm sure it will go a long way in helping others. Just check up on a friend and continue sharing our posts. Like us on our Facebook page at Pora Health, Instagram is Pora Health, and Twitter is also Pora Health. So to everyone, thank you so much for joining us. I'm sure Tino will end the meeting very soon. To those in Zimbabwe, have a great evening. Those all over the world, do have a good day ahead. Thank you.
Thank you.